The following presentation is In Vivo Systematic Desensitization for NeedlePhobia by Lindsay Ellenberger, Molly Lamb, Miranda Morton, and Ashley Walsh. NeedlePhobia occurs in 7 to 22% of the general population. Individuals diagnosed with an injection phobia and anxiety have a higher risk of other psychiatric disorders. Other interventions for needle phobia have included medications and physical restraints. Less intrusive methods have shown success in reducing the escape and avoidance responses of those diagnosed with needle phobias. Other research has included systematic desensitization with pictures of blood and needles, successive approximations of skin to needle contact, and successfully reduced escape-maintain behaviors for a man with autism and a client with diabetes. The purpose of the current study extends the findings of the Shabani and Fisher 2006 study to investigate the efficacy of an intervention in increasing compliance of an individual with a traumatic brain injury with needle phobia while being exposed to a needle. The limited research on an intervention for individuals with traumatic brain injury and co-occurring needle phobia warrants a need for the development of research with this population. The purpose of the current study was therefore to modify the investigation Shabani and Fisher 2006 used by adding systematic desensitization and ACT as a means to increase compliance of an individual with traumatic brain injury and co-occurring needle phobia during shorter distances between the individual and the response-provoking stimulus. Participants included in this study include 3 participants diagnosed with traumatic brain injury and needle phobia from a Midwestern outpatient clinic. The participants attended the clinic 3 to 5 times a week for speech and language therapy and behavioral therapy. Andy, Caucasian, male, 14 years old. Phil, Asian, male, 16 years old. And Sarah, Caucasian female, 13 years old.
Sessions were conducted in a 10 by 12-foot therapy room located inside the participants' regularly attended outpatient clinic. The room contained a padded blood drawing chair, a table with a tourniquet, needle, cotton balls, and bandage on it, located on the wall opposite of the blood drawing chair, and a 360-degree video camera in the corner of the room to record all sessions. Further materials included an instruction page out of the ACT book, a tourniquet, a needle with a cap, black electrical tape, a tape measure, data sheets, and edible reinforcers. The dependent variable in this study was the distance in centimeters between the needle and the participant's arm at the moment prior to the participant moving his or her arm outside of the designated parameter. The designated parameter was marked with an outline made with black electrical tape that was 3 centimeters in diameter in every direction. Each trial was marked correct if the participant moved his arm within the designated parameter, and each trial was terminated following any movement that breached the parameter. The distance between the needle and the participant's arm was measured at the end of the trial. On 100% of the trials, 2 observers independently recorded the subject's responses. Inter-observer agreement was calculated by taking the total number of agreements divided by the number of agreements plus disagreements and multiplying it by 100 to get a percentage. Agreement for the dependent variable was obtained for 100% of trials at a mean agreement of 98%. For this study, a changing criterion design was implemented. This design controlled for plausible threats to internal validity by using varied lengths of subphases in the intervention phase, as well as only changing to the next subphase after stable performance was observed. Each baseline session began with the participant sitting in the blood drawing chair in the presence of a BCBA and an RN. First, the RN cleaned the area of the arm that the needle would be inserted into. A tourniquet was then wrapped around the arm. The RN then walked to the other side of the room and picked up the needle from the table. The RN proceeded to take small steps toward the client until they displayed maladaptive behaviors or moved their arm outside of the marked area. Behaviors consisted of screaming, pulling away, saying no, or trying to leave the chair. Once the participant displayed any of these behaviors, the trial was immediately terminated. The distance at which the termination occurred was measured and recorded on the data sheet. A measuring tape was taped onto the floor of the treatment room, with 0 inches beginning at the foot of the blood drawing chair and extended to the table on which the needle was sitting. No demands were placed on the individual and no reinforcement was provided. Prior to each intervention session, the experimenters asked the participants what they preferred to receive as reinforcement. What would you like to work for today? The preferred stimuli varied for each participant and included edibles, videos, and tangible items. The intervention sessions were the same as the baseline sessions, except that each trial began with an ACT exercise and contained a specified visual criterion for distance away. After the ACT exercise concluded, the RN resumed the procedures of cleaning the specified area of the arm, wrapping the tourniquet around the arm, walking back to the table, placing the needle in her hand, and walking towards the participant. The RN walked in very slow steps, remaining in a straight line towards the participant while walking on the tape measure. The RN's arm that held the needle was held straight down by her side so that the distance in centimeters between the needle and the participants was accurately displayed by the tape measure on the floor. The floor was marked with black electrical tape to show the distance criterion to be met in order to receive reinforcement for that trial. If the RN's feet met the criterion distance, she said, "You have met the criteria. Would you like to keep going or stop?" The participant was then to respond, and procedures were continued or terminated as requested. The session was immediately terminated if the client moved his arm out of the designated area or engaged in maladaptive behaviors. Reinforcers were delivered contingent on the participant's arm remaining in the designated area, meeting the distance criteria, and not displaying maladaptive behaviors. The BCBA immediately approached the individual after the final trial and presented them with the reinforcer.
Baseline phases lasted until there was stable responding. The baseline phase for Andy lasted 3 trials, and the reported mean distance of the needle from arm in centimeters before moving was 61 centimeters. There was a slight upward trend in the baseline phase for Andy. The slope of the trend was m equals 2. The range was 4 centimeters. The baseline phase for Phil lasted 3 trials, and the mean distance was 56 centimeters. The range was 6 centimeters. The baseline phase for Sarah was 3 trials long, and the mean distance was 63 centimeters. The range was 4 centimeters. For each participant, there were 9 subphases throughout the experiment. Visual analysis of the data indicates an immediate level change in responding across all 3 participants at the onset of each new criterion level. The step-like fashion of the data across each participant along with the varied lengths of the subphases, exemplifies the relationship between the independent and dependent variable. Percentage of non-overlapping data between each subphase was 100%, indicating a highly effective intervention. 100% of the surveys were returned back at the end of the experiment. On each survey, 100% of the items were completed. The overall mean score was 4.7. The mean scores reported demonstrated that the participants perceived the treatment package to be socially valid. Results indicate that the treatment package, consisting of systematic desensitization and ACT, was successful in decreasing distance between each participant and the fear-provoking stimulus. All participants eventually allowed skin-to-skin contact with the needle and finally allowed a blood draw to occur. Results were consistent with previous research. A limitation of the current study was that data was not provided on generalization of the treatment over time once the BCBA no longer attended sessions. Future research should assess for and report maintenance of the behavior once the treatment is removed. Future research should assess the interventions separately and compare the results of each intervention to the other. Researchers should assess for the treatment generality across settings such as the doctor's office. Additionally, a larger group of participants should be used in future research to assess for generalization across participants. Future avenues of research should assess the efficacy of this intervention package on more diverse populations in different settings and possibly with other medical procedures. Populations with different diagnoses or other characteristics may react differently to the intervention.